obviously, the tremendous presentations that we've had this morning are certainly informative. What we are going to do is we're going to skip the panel discussion afterwards. And so I wanted to make sure everyone that had time for break, which is important, and then we'll move to the next session. But I think what's exemplified by these talks that we've heard, tremendous amount of information, tremendous amount of data. The difficult aspect is now how do we translate that and add to the care of patients. And I think it emphasizes the important role of individuals like Janet Talbert, who not only has expertise in the research and has more than a decade experience in familial pulmonary fibrosis as a researcher. That process led her to her next aspect of her career, which is becoming a certified genetic counselor, which she helps me on a daily basis and as a clinician at National Jewish and throughout the other aspects of the career. But hopefully you're aware she helps this community because she serves as a genetic counselor for patients on behalf of the Pulmonary Fibrosis Foundation, in which individuals can call and discuss complex issues with her. So I'm delighted to see that she's here today, and we'll discuss her experience and guidance in terms of translating the tremendous amount of genetic information to a very complex disease. So thank you for coming, Janet.
Thank you, Greg, and I want to thank the Pulmonary Fibrosis Foundation and Vanderbilt for inviting me here to speak. It's an honor. Also, it's my hometown. I was born right down the road, so been in Denver for 17 years, and so I think my southern accent's coming back this week. So thanks for that. Let's see, let me get this. So today I'm going to be talking about the impact of genetic information on families and patients. As Dr. Lloyd has alluded to, let me figure out. Okay. I also work for a company that gets great access as an oncology genetic counselor as well. But as Dr. Cosgrove said, I've been working in IPF since 2003, and I love the community, I love the patients, I love the families, so I'm not going anywhere anytime soon. So. All right, so we've already seen that there's a role for genetics in a significant proportion of pulmonary fibrosis. We've talked a little bit about genetic testing, and all of these things can impact patients as well as their family members. So, when to order genetic testing, what are the costs associated with it, how is it going to change, if any, medical management for the patient, or even a prevention plan for family members. What are the risks of relatives once a mutation is identified in the family? And I get this question a lot, especially with people without pulmonary fibrosis, is this going to affect my insurability down the road? And let's not forget, half of my title is a counselor, so there is a psychosocial impact. I always say genetic testing comes with a little bit of baggage. So I always borrow the slide from Dr. Garcia because it's great. And actually, you could put really any complex disease up here, and you're going to have a similar layout where you have the rare variants in the top left that are traditionally the Mendelian type of genetic conditions, where it's more like a single gene disorder, but you can tell there's no single gene to pulmonary fibrosis. So many of those have been described in the families. And then we have the new spectrum of the common variants also playing a role, whether it's in families or not, or in sporadic cases. So this is a traditional pedigree. Most cases are sporadic, no family history. And then if you contrast that with some of the familial pedigrees, they can be quite impressive. We've already seen some today, but they kind of come in all shapes and sizes. The definition is 2 or more individuals in a family, but you can see that sometimes we see families with multiple generations affected. We can see it in just a couple of people, cousins, or even in just one generation. So this is how I think of pulmonary fibrosis, especially the IPF, thinking about the genetic piece of it. The majority are sporadic, but about up to 10 to 20% is familial, and out of that 10 to 20%, about 20% of that is what we call hereditary, so linked to certain genes that we can actually identify a gene mutation. So when I think about genetic testing for patients, first of all, I always want to target the patients. I always say if you're looking for a needle in a haystack, start in the right haystack. So it starts by taking a detailed family history to see what the family is telling you. Is it looking like a dominantly inherited pattern? Is it recessive? Is it X-linked? Because our end goal is to get the right test for the right patient and really get them the best information. So the family history, we've already seen the telomerase pathway and the surfactant pathway. So looking for clues like age of onset, are multiple generations affected? Are there the spectrum of clinical features from dyskeratosis congenita, like liver cirrhosis or bone marrow failures? And none of those have to be in the same patient. They can be spread out across a family. So family members don't all have to have the same cluster of features, but it can cluster throughout the family. And then once you identify, and Dr. Lloyd did talk about panels, which kind of are the way to go these days, and cancer as well as these other disorders. What are the costs? Is it going to be covered by insurance? It's more likely to be covered, I think, when it's a diagnostic, like what Dr. Lloyd said, with the patient than unaffected family members. But again, you want to at least rule in or rule out any of the genes we can currently test for. And as Dr. Lloyd said, test results can be complex, and I'll go over that. It's really variant interpretation, and it can depend on whether it's a rare variant versus common variants. Common variants, you're looking at specific locations in the gene, whereas rare variants, you're scanning the whole gene to see if anything comes up. And that's why genetic counseling is recommended for any genetic testing, no matter who it is. And I know it is cumbersome sometimes, and there is an issue with access, which my society, my professional society, is trying to address. And yes, the model that currently is not very helpful, but genetic counseling can also be done by a clinician, physician too. So the American College of Medical Genetics has this scale for variant interpretation. So it's not black and white. And everything in red is considered actionable, meaning some kind of clinical utility can happen if a mutation is found. And then on the opposite side, whether a variant can be likely benign or negative, but more often than not, we end up with this variant of uncertain significance. And that's not considered an actionable variant. They do report it with laboratories, and it's important to counsel the family on what that means. Usually, if it's a pathogenic or likely pathogenic, you can test other family members. But when it's a variant of uncertain significance, the laboratory is saying we don't have enough information. And these aren't just reported mutations that have been reported in literature. The positives follow, is it a truncating mutation? Is it a frame shift? Is it a large deletion? Whether it's ever been reported or not, they're going to report it out as positive, but sometimes they just don't have that information. And we don't recommend any kind of clinical change management for a VUS, and not really testing for other family members either. And most laboratories, if that ever does get reclassified, they're supposed to issue a new report and get that back to the provider. So clinical management, I've already alluded to it. We already know, like in the cancer world, if you carry a gene mutation, how to treat you differently based on your mutation, or if you're at a risk. So we have some preventative strategies. In IPF, I don't think we're there yet. We have the ability to identify some mutations, but how that changes the clinical management for the patient is not well known right now. One could argue telomerase genes you could study, you could watch liver tests, liver function studies, hematological monitoring. I'm no physician, but especially if a patient is on medication, you're probably already doing that anyway. But it's good to be aware that there's a mutation for the patient to look out for other things. We've already seen today that the common variants can give us some prognostication for survival, perhaps. And in the future, maybe the future is closer than we think, therapies based on genotype, whether it's a common variant or a rare variant. So a lot of patients always say, what are the risks to my relatives? Or an unaffected family member will say, what's my risk? Having a family history of any disease gives you a risk for that disease. And it does appear to be greater to relatives in the familial forms because so many people are affected in the family. And we do know that based on these family trees, whether we find a mutation or not, there's already inheritance patterns. But do remember that common variants can be passed down in a Mendelian fashion as well, and that can affect sporadic as well as the familial cases too. And perhaps in the familial cases, it's compounded by common and rare variants. So this is, again, a definition of familial is 2 or more cases of IPF or an IIP. Patients in these families, if they already have the diagnosis, they're really concerned about risk to their children and other family members, and they're always asking, is there a genetic test, can I take it? Or if they don't have it, hey, I had 3 family members pass from this disease, can I just get a genetic test and it tell me if I'm gonna get this or not? And as you can see, it's pretty complicated. It's not that easy. So this is an area, especially working in cancer now, that I would like to be a part of is we don't really have any established guidelines for family members at risk. So, experts in the field have said if you have a family history, a positive family history of the familial form, perhaps some baseline screening, subsequent follow-up, but there's no guidelines out there that are evidence-based to tell us the efficacy of that kind of screening. So that's one area of interest I would like to be part of in the future. And Dr. Krotsky and the Vanderbilt group have already shown that unaffected first-degree relatives have already shown interstitial changes on CT scan and had abnormal biopsies. And perhaps if we knew ahead of time if people are at again, family history is risk, so whether you have a mutation or not, you can do all of these things now. So what I encourage unaffected family members to do is just have that conversation with their doctor about their risk and possible baseline screening, minimizing risk, smoking cessation, and such. So genetic discrimination, that's a big topic, especially for unaffected family members with known gene mutations in a family. What's my risk of my insurability? And in the past, this was mostly fear-based. There weren't that many cases of actual genetic discrimination, but part of it was because nobody would get tested because they were so fearful. So each state had their own laws, but the federal government came through in 2008 signing into law GINA, and it's relieved many of the fears. But what does it do? So GINA, the federal law, really just covers health insurance and employment. So in other words, a health insurer is not allowed to force you to get a genetic test, force a family member to get a genetic test. It's not allowed to set your premiums or decide coverage based on a genetic test. And employment, hiring, firing decisions, promotions can't be used against you. But what it won't do. It doesn't extend to elective insurances like life insurance or disability. So life insurance, it doesn't mean they will, but they can, and there's nothing stopping them from it. So if you have a positive genetic test result in your medical record and your life insurance is looking in, they could possibly use that against you. Now, it is important to know that it doesn't protect the manifestation of a disease. So if you already have a diagnosis of cancer or pulmonary fibrosis, a life insurer may use that against you instead of a genetic test. So a genetic test doesn't prevent that from happening. And it doesn't apply to certain groups, mainly because they have their own internal laws. So I think this is a part that we just all need to recognize, the psychosocial impact. I still have families tell me that their local physician or maybe even their local pulmonologist said that, no, this disease isn't inherited. It doesn't run in families. And we know from today and in the past that it does. So just recognizing that there is that inheritance a higher risk to unaffected family members is important, and that the patient is more aware of this diagnosis because they've already been through it with a family member, and maybe they've even been the caregiver, and now they're the one diagnosed. So it's a little bit more of a vulnerable population because they know this disease in and out. And, you know, everybody does want to know, especially when it's in the family, you know, what can I do for my children, my grandchildren? I know it's not going to help me. And so they do like to, you know, the patients like to participate in research, and even the family members like to participate in research, and I was part of that research. And there's a couple of research studies here today, so if anyone's interested, clinicians as well as patients can look into those because they're great. But overall, they're greatly concerned for their relatives. There's risk and benefits to genetic testing. I think learning your genetic status is a risk as well as a benefit, just knowing you have something. But it can also be empowering to say, okay, this is, or an explanation, because so many people ask why. We've already talked about some of the risks for monetary, as far as there could be a cost to the genetic testing itself, genetic discrimination. But I think the benefits end up outweighing the risk just because so many people can use that knowledge to empower themselves through different mechanisms, whether it's screening or preventative plan, if we can ever get there, and just peace of mind, knowing what's happening in the family. So I always point patients to different resources. Of course, Pulmonary Fibrosis Foundation, great resource. I don't know if you've heard of them, but great organization. And then clinical trials where they can go for research, whether it's clinical trials or research studies for familial or genetics, and the GINA information as well. And then as we created the telephone-based genetic counseling in 2008. Over the years, I do this part-time as my role to still stay as an affiliate with National Jewish. And I can talk to providers if you have questions about panels or where to order or genetic testing, as well as patients as well and their family members. So everyone's free to give me a call. Just don't all call at once. And these are my references. So thank you. I want to thank everyone again. It's a privilege to be here. So thank you.